Good day to all of you, and I'm going to talk to you about a diabetic foot and its relationship to neuropathic aspects. My focus of today's talk is going to be on the pathogenesis of neuropathy, some features on the management of neuropathy and aspects of foot care, preventive aspects, formation of ulcers, and the concept which has been long neglected but not too infrequent called neuroarthropathy. The first question I would like to answer is, what is the frequency of diabetic neuropathy? If we look at this particular study which we had published about 5 years back in the Journal of Association of Physicians in India, it's a consolidated bit of data which is fairly simplistic, obtained from 4 major centers, including Christian Medical College, Vellore. In all these centers, ranging from the private sector down to government medical colleges, a central government college, and our own center, the prevalence of neuropathy in the outpatient clinics varies from 14 to 17%. So, diabetic neuropathy is a common complication, and depending as to what method you use for screening, the prevalence is fairly significant. Prior to these studies which have studied diabetes prospectively in terms of type control, namely the DCCT and the UKPDS, studies have been done to look at the proportion of diabetics who have neuropathy after 20 years of diagnosis. And it has been found that almost 50% of subjects who have diabetes at the end of 20 years have symptomatic neuropathy, which includes positive as well as negative symptoms. And when we talk about positive symptoms, we essentially mean symptoms like pain or burning. And when we talk about negative symptoms, we refer to numbness and tingling and loss of sensation. 50%, that's a big proportion. Asymptomatic neuropathy was present in about 40%, which means if you are using a monofilament or a tuning fork for assessment of neuropathy, there's 40% of subjects who have this kind of a problem. And no neuropathy was seen in only 10%, which means that basically around 90% of subjects at the end of 20 years have some form of diabetic neuropathy. The WHO definition for diagnosis of neuropathy is a functional one. It's characterized by a decline and damage of nerve function, leading to a loss of sensation, ulceration, and subsequent amputation. The pathogenesis of diabetic neuropathy is largely that of a small vessel disease or a microangiopathy. This picture shows blockage of a small blood vessel which feeds a nerve, and subsequently diabetic peripheral neural damage is of 2 types. It could be due to an axonal damage or due to demyelination. The axonal damage may also be attributed towards a subsequent regeneration, and as the nerve fibers reconnect, it leads to certain positive symptoms like paresthesias or perverted sense of pain. There are a number of risk factors associated with the onset of diabetic neuropathy, and these include, of course, poor glycemic control and the duration of diabetes. What is also important to remember is that when you have neuropathy and if you're walking, you're more likely to injure yourself and cause mechanical injury to nerves. These nerves are more susceptible to further deterioration in their function and lead to a worsening of neuropathy in turn. A genetic susceptibility has been reported in diabetic neuropathy. However, the genes which govern onset of diabetic nephropathy are far more dominant than that and those which govern diabetic neuropathy. A combination with other exogenous factors like alcohol ingestion may worsen neuropathy and lead to an added cofactor. So more recently have also been other cofactors like smoking and increased LDL cholesterol and cardiovascular disease being attributable risk factors. When we classify diabetic neuropathy, we divide them into several categories: symmetric polyneuropathy, autonomic dysfunction, polyradiculopathy, mononeuropathy. I'm not going to talk much about autonomic dysfunction in this particular lecture. Symmetric polyneuropathy, however, on the other hand, is the commonest form and basically is largely that of a glove and stopping type of neuropathy. We very often forget the glove component. We always think that it's largely in the lower limbs, which is not really true. About 40% of patients with diabetic neuropathy have upper limb involvement in addition, and the associated symptoms could be positive with that of pain, paresthesias and dysesthesias, loss of vibratory sensation, and this diagram of course shows you the typical glove and stocking distribution, and you should remember that it can go right up to the thighs and up to the shoulders in certain situations. It's important to look for motor features like wasting and weakness in the fingers and in the palms. A small fiber neuropathy is apparently less common and involves largely the alpha and C fibers. It can be burning and stabbing. It tends to be more severe at night, and this is basically the opposite of what might happen in a venous insufficiency, where patients would actually have more pain when standing during the day. Large fiber neuropathies involve electrical tingling or a snug-like band around the ankles or feet, and patients may have a sense of imbalance with a gait instability which may be prominent. When we talk about neuropathy, we should talk about the evolution of foot ulcers. Ulcers are largely due to a neuropathic origin, even though they may be ischemic and infective components in addition. It's interesting to note that one would have actually thought that fissures on the feet of patients are largely due to trauma or due to barefoot walking in our country. However, in subjects who have diabetes for a duration or period of time, there may be a decrease in sweating or sebaceous secretion due to autonomic neuropathy. And this leads to dryness of feet, cracks on the feet called fissures, pebbles or small bits of dust may get stuck in between these fissures, leading to trauma and infection. Collection of pus may increase, leading to abscess formation, and a breakdown of these abscesses leads to ulceration. Besides the fissure story, there is also the callus story, which has a motor origin. In these subjects, due to a deformity, due to motor neuropathy, which is essentially most commonly that of clawing of the toes, it leads to abnormal plantar pressures on the soles of the feet and leads to thickening of the skin, which is called a callus. This callosity should be ideally removed at the earliest. However, if it's not removed, trauma may occur on the surface of the callus, leading to formation of a callus hematoma, and subsequently, of course, these hematomas are more prone to infection and abscesses may subsequently form. Breakdown of the abscess once again leads to the formation of an ulcer. So the etiology of foot ulcers could be therefore a combination of an absence of sensation in the presence of trauma, ischemia, foot deformities due to advanced neuropathy or callus formation, autonomic neuropathy, a condition called limited joint mobility, where there's tissue glycosylation and tendon glycosylation, leading to tendon contractures and thickening of the skin. There may be impaired wound healing in the presence of uncontrolled diabetes, and patients who have diabetes may have cataracts, macular degeneration or retinopathy, which can impair vision, and this subsequently makes it more likely for trauma to occur to the feet. Poor footwear is very often not taken into account, and of course poor footwear can also lead to ulceration if footwear is too tight or too loose. When you evaluate the feet, you should look for a number of deformities. Like bunions, a common deformity is that of hallux valgus, where you essentially have a deviation of the big toe, claw and mallet toes, scars, and even previous amputations. One should always remember that an amputation stump in a patient with diabetes may have distal peripheral neuropathy. And this stump is more likely to get infected, and if you have an improperly fitting prosthesis to the stump, it may in fact lead to trauma and ulceration of the amputated stump. Here are some of the abnormalities which I described: mallet toe, hammer toe, and claw toe, hallux valgus, which may be mild or severe. And one should note that the proximal interphalangeal joint over here on the big toe juts out in hallux valgus, and therefore may be a point where trauma may occur and become more prone for both ulceration and subsequent direct infection into the joint, leading to septic arthritis and osteomyelitis. When we evaluate a patient's feet, we need to feel for rough and reddened skin, which is basically indicative of autonomic neuropathy, fissures as I mentioned before, lack of hair, which leads to neuropathy and peripheral vascular disease, too warm, which indicates an infection, or too cold, which indicates peripheral vascular disease. For clinical evaluation, you need to look for pressure points, and callus hyperkeratosis from mechanical stress may occur, as I already mentioned. Some of the common examples of constant pressure or friction include deformed bones of the feet due to a neuroarthropathy, a toenail pressing against the adjacent toe leading to trauma itself, tight shoes, or a shoe with a torn inner lining, or with very narrow pointed toes, which is bad for a subject with diabetes. Corns occur on the dorsum of the foot and are thickened skin. Similarly, callus occurs on the plantar surface as mentioned before. The nails of subjects with diabetes are prone for a number of pathologies. One such includes fungal infestation of the nails, which is basically a condition which leads to thickening of the nails, which are very difficult to cut with a normal nail cutter, and may in fact require pliers or bone cutters for snipping through them. The infestation of fungus may in fact involve the toes, causing erythema or curdy white appearance between the phalanges. Ingrown toenails are another common pathology, and it's important to remember that when we cut the nails of subjects who have diabetes, to cut them right across the top and not cut them too close to the nail beds. One should be cautious while snipping the nails and leave a margin behind, otherwise damage might occur to the nail bed, leading to infection and subsequent disastrous consequences. The next issue is that of a diabetic ulcer. And how do we diagnose a diabetic ulcer? There are two major categories: superficial ulcer, which is simple and has a clean base with no discharge at all and has no swelling of the foot. Here's an example of a superficial ulcer. The simple ulcer needs to be treated as mentioned simply. We need to keep the ulcer clean, and this can be done with normal saline. No necessity for antibiotics or any other applications. And of course, offloading of the ulcer is required with non-weight bearing on the ulcer. A total contact cast may be required if the ulcer has not healed for a number of months. And then of course you have the complicated ulcer, which may be deep, involving the tendon, joint or bone, and has a lot of pus and discharge. There may be an overall erythema with warmth and swelling of the foot. Complicated ulcers may very often extend into the deep tissue, and there may be slough along the tissue planes. Here's an example of a complicated ulcer. As you can see, there's fullness on the plantar surface of the foot. Very important to dissect this kind of an ulcer and see whether it extends, as you can see over here, deeper into the tissues with a lot of pus, and liberally extend the incision. And you can see that it's gone a fair distance. It may be necessary to in fact do a skin graft subsequently for patients who have such large ulcers once they have healed totally. These are the monofilaments which we use in diabetes, mounted on this contraption, and it's important to remember that the standard ADA criteria will tell you that it's only necessary to do a 2 gram and a 10 gram monofilament testing. In leprosy we go up to 300 grams. A loss of protective sensation is apparently detected when a 10 gram monofilament cannot be felt. From our departmental perspective, we feel that this may be too late. We do a sliding perspective of 2, 4 and 10 grams. Vibration assessment may be done with a tuning fork or with a more sophisticated device called a biothesiometer. Now over here you can see that when you check with the monofilament, there are ideally 9 positions on the plantar surface plus a 10th one on the dorsal surface for assessing neuropathy with the monofilament. However, in situations where there is a lack of time or a large number of patients, you may be permitted to check on 3 points on the plantar surface, under the big toe, on the lateral aspect of the plantar surface in the anterior position, and on the surface of the calcaneum, plus 1 on the dorsal surface. This is a biostereometer, which is essentially a glorified tuning fork and can be used for assessment of vibration in a graded manner. As you can see, there's a dial and you can go up to 50 millivolts. If you have a neuropathy, the recording is usually more than 15 millivolts when it's mild, more than 25 when it's moderate, and more than 40 when it's severe. In patients who are elderly, one may be permitted beyond the age of 70 to say that there's neuropathy when the millivoltage is more than 25 millivolts. So how do you prevent bad things from happening to the foot? Proper prevention basically means good callus and fissure care. After a bath, it's important to soak the feet for at least 10 minutes exclusively in warm water. Use a pumice stone for smoothing out the surface of the foot. If you don't have a pumice stone, you can use a nylon dish scrubber. Keratolytics are controversial. However, we believe that 6% salicylic acid can be used on the surface, on the plantar surface of the foot. If a callus is very thick, it needs to be trimmed down with a scalpel. Of course, this has to be done by experienced hands. Toenails can be softened when soaking feet for 10 minutes. After a bath, one needs to soak the feet exclusively for a period of 10 minutes, and this will soften the nails. So one would cut the nails immediately after they have softened and then file the corners so that no nail hangs off. We tend to leave a little bit of nail behind, as mentioned before, and thick nails can be filed down with an emery board, or they could be cut with clippers or a razor. Now, special footwear can be used for insensitive feet, and this would include microcellular rubber slippers. Custom-made shoes can also be utilized to shift the pressure away from the area of deformity. Even socks are important. Socks should be generally made with cotton rather than nylon, because nylon does not absorb moisture, and moisture can obviously lead to fungal infestations. So cotton therefore keeps the feet dry and clean. Wrinkles are bad and can act as pressure points, and if the socks are too tight, they can lead to ischemia. So how does actually one treat underlying diabetic neuropathy? Of course, of prime importance is good glycemic control. A patient may have pain, and of course foot care, which I have already mentioned in great detail. The list of drugs for treatment of painful peripheral neuropathy is large and vast. However, one can broadly divide them into antidepressants, anticonvulsants, antiarrhythmics, opioid derivatives, and other analgesics. So the anticonvulsants are effective in neuropathic pain, and essentially they can be used particularly for the burning, tingling, electric shock types of pain. Carbamazepine is the cheapest effective drug, and the doses which are used are much smaller than that used for treating convulsions. Just about 100 milligrams thrice a day may be enough to control pain in some subjects. Antidepressants like that of amitriptyline, which is the best studied antidepressant drug in the treatment of neuropathy. Dosages of around 25 milligrams at bedtime, up to a maximum of around 75 milligrams, which is much less than what is given for treating depression, are highly effective. Amitriptyline, of course, even though being the most effective drug for treating diabetic neuropathy, has very definite contraindications, which are common in those who have underlying diabetes. If you have underlying ischemic heart disease, which is common in 30% of those who have diabetes above the age of 60. If you have prostatomegaly, you cannot use tricyclic antidepressants. And of course, in the presence of glaucoma, you may not be able to use these drugs in addition. Second generation anticonvulsants like gabapentin and pregabalin are well absorbed and not metabolized. The Indian requirements are much less than what you actually give for subjects who have neuropathy in the West, and a maximum dose of 600 to 900 milligrams is adequate. So the algorithm for painful neuropathy basically looks at two types of pain that we see in diabetes: the paresthetic, burning, electric, shock-like pain, which responds best to either amitriptyline or an anticonvulsant. You could even try a combination of an anticonvulsant and an antidepressant together, even though there aren't many controlled trials looking at these combinations. For more deep-seated dull aching pain, paracetamol would work, and if it's refractory, one would add on a semi-opioid agonist. Tramadol in combination with paracetamol. Topical applications like capsaicin can also be tried, and in the most refractory forms of pain, which are chronic and require long-term treatment, transcutaneous electrical nerve stimulation, or TENS, can be utilized. Finally, a word about one of the most perplexing problems in diabetic neuropathy, and that is Charcot's neuroarthropathy. Once thought to be a rare offensive condition, Charcot's neuropathy is in fact an under-recognized disorder which is seen with reasonable frequency in those who have chronic diabetic neuropathy. The Charcot's foot is caused by repetitive trauma in the presence of a diminished sensation and significantly reduced proprioception. In addition, they have a motor neuropathy which leads to abnormal weight bearing and imbalance. And the end result is the classical rocker bottom deformity. In patients who have Charcot's neuroarthropathy, the presentation would include an acute swelling of the foot with warmth and erythema, which may in fact mimic an inflammation or cellulitis. It is usually unilateral, Bounding pulses are seen as a feature of this disorder. Pain is present, but is less than anticipated, and only in about 30% of subjects who have Charcot's arthropathy. An ulcer may be frequently present as well. When one does an X-ray of the foot, there may be a combination of a number of heterotopic changes, and the bones may be fragmented. This is an example of a Grott's Charcot's arthropathy, which has involved the arch of the foot. To understand the pathogenesis of Charcot's arthropathy, one has to look at the anatomy of the foot. The transverse arch has the cuboids and the cuneiforms, and the bases of the first to the fifth metatarsals. The medial longitudinal arch consists of a calcaneus, a talus, 3 metatarsals, and the navicular and cuneiform bones. The lateral longitudinal arch consists of a tubercalcaneum, a cuboid, and the fourth and fifth metatarsals. If you look at the segments of the foot, you can have metatarsals and phalanges in the forefoot, the midfoot having a cuboid, navicular, and cuneiform, and the hindfoot having a calcaneus and talus. The Sanders and Mazonovic anatomical classification of diabetic neuroarthropathy consists of 5 basic types. Pattern 1 involves the forefoot, pattern 2 the Liffrancs joint or the base of the first metatarsal, pattern 3 the lesser tarsus, pattern 4 the classic neuroarthropathy which involves the ankle, and pattern 5 which is basically a deformity which involves posterior dislocation of the calcaneus and displacement of the posterior pillar. The most common, however, is pattern 2 or involvement of Liffrancs joint. The adult flat foot can be diagnosed appropriately from X-rays using a standing lateral view to look at various angles which can be measured. This is Miari's angle, which looks at a perpendicular drop from the top of the talus and a line extended from the back of the talus to the front of the big toe. This is normally an acute angle. However, when it becomes obtuse or greater than 90 degrees, it is pathological, indicating a collapse of the arch of the foot. The longitudinal arch can also be measured with the calcaneal pitch, and the normal is around 18 to 20 degrees. If it becomes more acute, it indicates a collapse. This is an example of the Liffrancs joint with a dislocation, and the X-ray which is taken to view this best is the antro-oblique lateral, where there is no interference between the bases of the metatarsals. This is a typical pattern 4 ankle involvement, where there is descent of the talus. One can also see a number of bone fragments and sclerosis of the bone, where the base of the tibia meets the top of the talus. Patterns 2, 3, and 5 in combination, where Liffranc, lesser tarsus, and posterior pillar are all affected in the same patient. And here's another example of pattern 3 and 5 with involvement of lesser tarsus and posterior pillar at the same time. This is another grossly deformed foot with pattern 4 or descent of the talus, and you can see it coming right down over here. When one investigates Charcot's arthropathy, one cannot use it to differentiate an infection by using a bone scan. A technetium bone scan over here shows bilateral involvement of the feet, bilateral Charcot's joint. Here is distal or type 1 disease, which is largely atrophic and which can actually mimic a patient with psoriatic arthropathy, a typical pencil and cup appearance. Here is a hypertrophic disease involving sclerosis and hypertrophy of the periosteum. Here is a very gross atrophic disease on a CT scan showing a moth-eaten appearance of the bones. One of the best ways to differentiate Charcot's arthropathy from osteomyelitis is doing an MRI of the foot. One may need to look at the T1 weighted images, which shows a low marrow signal, and a T2 weighted image which shows a high signal. Here's an example showing a foot with the T1 and T2 weighted images. You can see the very bright signal indicating an infection. So how do you manage neurodegenerative foot disease? The first thing is to keep the foot end elevated and wait for the edema to subside. This may be necessary for 3 days or for as long as even 2 weeks to reduce the edema significantly. Applying a total contact cast is necessary. What this basically does, it reduces mobility and therefore friction and trauma between the bones, and the bones subsequently fuse together, leading to a pseudoarthrosis. There's support of the muscle pump, and this reduces edema at the same time. A total contact cast needs to be applied for a fairly long period of time to achieve a good pseudoarthrosis. And if you have minimal suspected fractures, 8 weeks may be enough, or it may even range up to 6 months, and in occasional cases where you have gross dorsal talus disintegration, you may need up to a year with a total contact cast, but it is extremely effective. Here is a total contact cast, and here's an alternative which is definitely not as effective, because anything which can be removed periodically at night, like the air cast boot, is likely to be less effective than a total contact cast. Management of the neurodegenerative foot disease involves good plasma glucose control, as always, and also involves reduction of inflammation and osteoporosis. And this can be effectively handled by giving a bisphosphonate. Intravenous pamidronate has been tried. However, now the state of the art is to give alendronate on a once weekly basis. So let me summarize by saying that neuroarthropathy and neuropathy in diabetes is a common problem that requires both preventive and therapeutic aspects to be dealt with in an intensive manner. Teamwork is extremely important in handling this kind of a problem, and it will have a significant impact in preventing subsequent foot disease and ulceration, and it should be handled from a community health perspective. Thank you very much for your patient listening. I'd be happy to answer any of your questions.